Recording from last time, is it really loud?
Yes.
It was.
Oh.
I turned it. Did it get better toward the end?
I had to cut it down.
Yeah.
It was like flaring when I first cut it on.
I've got it turned down further, so hopefully it won't. Remember that today we'll cover these few disorders, and then we have a guest that will be here, and so make sure that you've got good questions about MS for her. All right. Test? What? Guest. Mm-hmm. I told you last week, remember? No. So we finished RA last time, right? Let's talk about lupus. This has a long name, so now you know why we call it lupus. This is similar to rheumatoid arthritis. It is a chronic autoimmune disorder. And the key difference to me is that in rheumatoid arthritis, it focuses more on the synovial membranes. But in lupus, it really affects the whole body. So, again, with these autoimmune disorders, women affected more, right? And minorities. So, the patho, I probably put too much in here, but the patho is similar to rheumatoid arthritis, but there's autoantibodies, and they attack mostly connective tissues, blood, lung tissue, and things like that. And the tissue is damaged because of that inflammatory response, the autoantibodies. The kidneys often take a big hit in lupus, but the whole body, like I said, can be affected. One of the systems that we see most easily is the skin that is affected in people with lupus. This is also similar to the diagnosis of rheumatoid arthritis, so our inflammatory markers. We also, with lupus, we measured the ANA anti-nuclear antibody and the anti-DNA antibody. These are specific indicators. They are somewhat sensitive, but they don't always show up when a person has lupus. Just like with rheumatoid arthritis, rheumatoid factors aren't always positive with rheumatoid arthritis. That's why we do the anti-CCP as well. So here are some. These are manifestations in the blood from lupus, and that helps with the diagnosis of it. The urine is measured closely because when there is kidney damage, you'll see blood in the urine and protein in the urine. So that tells you that the kidneys have been affected by lupus if you see those abnormalities. And then also, renal function. All right. So I just made this slide. These are general manifestations. I'll talk more about manifestations of it. But this picture here is this classic butterfly. This person has a butterfly rash, but they also have this discoid rash. The butterfly rash is normally just red on the face, but the discoid rash is actually where it is raised. So this person has a combination really of both. And the unique feature of this rash is that it spares the fold right here in the nose. The nasal labial fold is what they call this. So see how this is not affected, this little area right here. And that gives the shape of butterfly wings. Okay. So they're very sensitive to the sun. I'm not going to read this to you, but these are general manifestations. And generally in this disorder, the manifestations get worse than better, and so the person is not always at a state of inflammation, so they can improve and then get worse. So when you hear the terms wax and wane, that's what that means. As in most disorders, stress and illness can make it worse. This is the diagnostic criteria for lupus regarding manifestations. So you can remember these because of this acronym here. And just understand what it is, because we can talk a little bit about the Malar and the discoid rash and all of these things. But I think most of these you can just look at it and understand what it is. So know what these things are and what they represent, these manifestations. Okay. A person would need to meet at least 4 of these to receive a diagnosis of lupus. So their ANA is positive. They'll assess the patient's history and the physical manifestations at that time for these things. And then they'll get the diagnosis. Sometimes they won't even have an ANA positive, but they're having, 8 of these manifestations. They're probably going to go ahead and say, yes, you have lupus. Yes, ma'am.
With the pleurisy, is that just having it ever or at the time?
It's having it ever. Yeah, because like I said, the manifestations, they come and go. Yeah. But they could have several of these at one time, for sure. But it's a history of these are current. The biggest complication, which I didn't put here, but I mentioned, was a renal complication. But there's system-wide complications from lupus. Low platelets, so there's risk for bleeding. Alveolar hemorrhage, so that's a risk for pulmonary edema, things like that. Pulmonary clot in the lungs, things like that. Raise your hand. So we talked about the medications for rheumatoid arthritis, and it's about the same for lupus. Anti-inflammatories, the anti-malarial, the Plaquenil, remember the eye complication there. You know all about steroids and why you shouldn't stop abruptly, and lowering or stopping abruptly and lowering the dose may cause the lupus to flare. Just like with rheumatoid arthritis, methotrexate, and that's an immunosuppressant, so it helps with the autoimmune process in these disorders. Because they are, basically cancer medications, so they will cause probably pancytopenia. Risk for infection. I like these pictures. So the person has this butterfly rash. Sensitivity to light, the complications here, respiratory, cardiac, and renal. So like I said, photosensitivity is a big deal with people with lupus, so make sure that you're teaching them to wear lots of sunscreen, and at least SPF 15. And these times, between 10 and 3, are the times at which the sun is most potent outside. So teach them to do their activities in the morning, or in the afternoon, later in the afternoon if they have to go outside. Wear hats, long sleeves, things like that. Skin care, all of those things. Topical steroids can help with that rash on the face, but really in general we don't put steroids on the face, but you can put low dose steroids on the face for a short period of time. Risk for infection, right? So do those things to prevent infection. Make sure that, especially if the person is on methotrexate or something like that, understand that that person is at high risk for infection, so intervention must be taken to prevent it and to be able to identify it. The risk for bleeding because of the low platelets, also with those cytotoxic medications. What about this? Nurse's most important intervention to prevent infection in immunocompromised lupus patients. It's hand hygiene, right? So just remember that hand hygiene is the single most effective way, right, to prevent the transmission of disease. Sometimes questions seem too simple, and sometimes they just don't. That was exciting, wasn't it? It's not a lot to lupus. It's a lot like rheumatoid arthritis. The medications are similar. It's just understanding that there are different manifestations, that it affects the whole body, and your kidneys also take a big. All right, so multiple sclerosis, we'll call this MS. It's another autoimmune disorder. Middle or early adulthood, and again, more women than men with these autoimmune things. It is possibly genetic, and also there is a link to a viral cause. So the nervous system is affected. So the one theory, like I said, is that there was a viral infection at some point, and that caused an abnormal immune response, and that made the body build antibodies to the myelin sheath of the neurons. So, therefore, the myelin is lost, and you have to remember the function of the myelin. You remember that there's the neuron and the dendrites and all of that, and on the axon of the neuron is the myelin sheath, and it works as a insulator. So think about just an electrical wire, and it's got the plastic on the outside of it. That's the myelin sheath. So multiple sclerosis, the autoimmune process is breaking down that myelin sheath. It's either broken down or scar tissue develops and it doesn't act appropriately. So therefore the nerve impulses and transmission doesn't happen like it should. So this is the axon, the myelin sheath, right? And this would be normal, but here you have a breakdown. So just imagine if you had an electrical wire that was didn't have the covering on it, or if you have rats in your attic or something and they're biting on it, what's going to happen? It's going to short out. It's going to shock. It's going to cause fire, right? So the transmission doesn't happen properly. So normally the impulse travels from the dendrite down the axon, and that myelin sheath helps it go along. But here it gets stopped or delayed because the myelin sheath is damaged. A person with multiple sclerosis is not going to have manifestations. They go to the doctor and oh, you have multiple sclerosis. They're going to rule out a lot of different things, thyroid issues and musculoskeletal problems, maybe lupus, maybe rheumatoid arthritis. Often those diseases are comorbid, but it's a diagnosis of exclusion. And when you see that term, it means that other things have to be ruled out before we can call it this. An MRI will tell us, or can help us see the damage of the neuron because of the breakdown of the myelin sheath. And often the person with multiple sclerosis will get serial or frequent MRIs to assess the progression of the breakdown of the neurons. These OCBs can be found in the CSF, but this normally isn't done. Normally the MRI is done more. There is a criteria to diagnose MS. It's a manifestations and things, but you don't have to memorize that criteria. It's just I just wanted to tell you that. But again, other things are ruled out. So blood studies, thyroid and things like that, testing autoimmune antibodies and things. But there's really no abnormal blood findings with a person with MS. So manifestations it varies, but usually the person with MS has lots of musculoskeletal signs and symptoms and lots of weakness. So paresthesias, remember what that is, and it's tingling, numbness in the extremities, and there's the motor signs and symptoms. So the musculoskeletal, difficulty walking. And to treat these signs and symptoms, here are our medications. So physical therapy obviously would be an excellent consultation for a person with MS that has these manifestations, but likely will. You all know about baclofen already because you studied neuro and understand how it works and know the side effects and things of baclofen, the skeletal muscle relaxants. This Ampera, it's for the walking, and it's a potassium channel blocker. And it helps the transmission of the impulses get where it needs to go so that we can have muscle contraction and action. And gabapentin is more for paresthesia, or for the pain, the nerve pain. So gabapentin is for that. Benzodiazepines, which you know all about. It would help with spasticity. These are spinal cord manifestations, and we call this autonomic, right? So you know about these because you studied spinal cord already. So these GI, GU manifestations, and sexual dysfunction. So this person has a big risk for UTI because they would have maybe a urinary retention and things like that. So maybe, have you guys studied ditropania, those urinary drugs, maybe mental health one? No, you didn't study urinary, what do you call it? Urinary Incontinence.
Incontinence.
Yes. So, so Ditropan, remember, there was the commercial that I gotta go right now. So that's, you would give that to help decrease the spasticity of the bladder. So that person, the decrease in incontinence. So a person with that incontinence signs and symptoms, they feel like they have to go, but then they go, and it's just a small amount that comes out. It's just because the bladder is spazzing and squeezing. So all those interventions to decrease urinary signs, so limit fluids in the evening, so that they sleep well. All right. And for, of course, for sexual dysfunction. So when the cranial nerves, specifically 3 and 7, are affected, optic neuritis can become a big problem. Sometimes, or often, this optic neuritis is one of the first manifestations of the patient moving forward. So that changes in vision. I think anytime a person has changes in vision, it worries them, and they're going to report it very soon. So often this is the first thing that is reported. Also, there's, because of cranial nerve 7 that is affected, the facial weakness and difficulty articulating speech can become a problem. All right, so steroids for that, and of course, insulin. A person will most commonly report these things as well: fatigue and pain. Let's see. It's not only physical fatigue, but also mental fatigue. And these medications are experimental. This, of course, is a stimulant, and it can help with increased energy and focusing. And Nuvipl is a medication that is used for narcolepsy. Yeah, so this helps people stay alert in a way, mental alertness here. The pain in MS comes from the actual breakdown of the myelin on the neuron. So these people report this terrible gnawing pain. And again, because it's a nerve pain, gabapentin is a good choice, but dilantin is too. And the tricyclic antidepressants are often used for pain, for nerve pain. It's one of those things that, it's not necessarily off-label use anymore, but one of those things that maybe you wouldn't initially think of that would help with pain in an antidepressant, but they do. Especially in, what is that disorder where the whole body is affected, they're always tired. Fibromyalgia. Yeah, tricyclic antidepressants are often used for that too. And then because the patient will have these musculoskeletal manifestations, they will have posture problems and balance, and they can have secondary pain because of that. Anti-inflammatories, try to avoid bronchitis. We talked to heat. We talked about manifestations of mental manifestations too, because it affects the central nervous system, right? What else did I say about that? Oh yeah, this is important here. So the person that has MS, if they become overheated, it will cause an exacerbation of their symptoms, because when the person is overheated, it further impairs nerve conduction. So teach them to avoid extreme temperatures, especially hot environments. There's different types of MS, and it's simply you need to understand the difference between the different types. So realize that relapsing remitting means that it has a remission. So that means that the patient will have an exacerbation, but then all the manifestations go away, so that they will feel normal at some points, and then sometimes they'll feel like they had MS. Progressive relapsing is where they, of course, will have manifestations or exacerbations, but then they have improvements, but it never fully goes away. So that's what that improvements mean. It doesn't remiss. It simply improves. Primary progressive, it just gets worse. It's more predictable, but there's not necessarily a lot of exacerbations, and so not a lot of fluctuations in symptoms. It just progressively get worse with the manifestations. but this is very similar to primary progressive. It's secondary progressive, but it's less predictable. So one day, they may, or for a while, they may be trucking along at about the same rate, and all of a sudden they get a lot worse just out of nowhere. But with primary progressive, it's more steady.
Are there any that's more common?
I'm not sure, but I think that progressive relapsing is pretty common.
On the increased sense, is that with the hypothalamus? Anything to do with the nerve connection to that?
No, it just means that they're sensitive to high temperatures. Yeah. She asked if there was damage to the hypothalamus because of this. No, it's just they're sensitive to high temperatures. Another picture. So, all the manifestations: urinary, bowel, the musculoskeletal signs and symptoms, and the vision changes over here. All right. The person, we give immunomodulators. It's similar to immunosuppressants, but it's interferon 1A and 1B, and there's a few more names for these types of immunomodulators. But these are disease-modifying agents. So in rheumatoid arthritis, we talked about DMARDs, right? But this is the same thing. But we can call these DMAMs, disease-modifying agents for MS. So this decreases the autoimmune process, decreases the demyelinization of the neurons. It's toxic to the liver. It is injected. What else? It's not necessarily contraindicated in pregnancy, but the person will be followed very closely. The person with MS, we would encourage them not to be pregnant anyway. But what else? Yep. The steroids in this case, they don't decrease the breakdown of the myelin sheath, but it helps with the manifestations, so it can help with those exacerbations of the disorder. Again, we can use these immunosuppressants, these cytotoxic medications like we do in lupus and rheumatoid arthritis to decrease the autoimmune process. But again, pancytopenia, the risk for bleeding because of the low platelets, jaundice would be because there's liver problems. And again, these medications are contraindicated in pregnancy because these medications also kill cells that are rapidly dividing, aka an embryo or fetus, right? Here are some things that we nurses can do. I've mentioned some of them before, but to help with fatigue, teach them to perform activities when they're feeling well, to cluster their activities. And usually in the morning is when the patient will have more energy. The hot temperatures again, which can exacerbate symptoms. Maybe braces to help with movement. And what a plate guard is, it's this little, it's like a half moon shaped thing, and it's put on one side of the plate so that the person can get the food on the foreplate, push it up against it. I think that they're often used when a patient has had a stroke as well. It can help them get the food onto the screen. So that maybe one arm is weaker, or that other hand has to hold the plate. So it can become a challenge just to eat. So the person is at risk for falls. They have decreased muscle tone. They have muscle fatigue. So make sure that we assess the home and teach them to decrease their risk for injury. Speech articulation, we mentioned because that was because of the cranial nerve being affected, cranial nerve 7 here. So teach them, again, we've learned about these things before, but teach them to think about their speech, to think about articulating and have deliberate speech. Swallowing because of the musculoskeletal impairment of the neck, so a risk for aspiration here. Good stuff in it. All right. Myasthenia gravis is more uncommon. I thought that when I was in school, I'm never going to see a case of this, and it went for a long time, years, and I never thought about MG again. And then I think it was probably last month I was at the Med, and we had a patient who had myasthenia gravis. I was like, what? You know, so it does exist. It's very rare, 2 in a million. So it is also an autoimmune disorder, and it's where the I'll talk about that. But it's a problem with acetylcholine receptors. This is one autoimmune disorder that doesn't affect women overall more, but in younger groups, when diagnosed, women are diagnosed more, but in older groups, when they're diagnosed, men are diagnosed more. But overall, it affects both sexes equally. Asians have a slightly higher disposition to this. So what's happening here is that the autoantibodies have affected this here is a neuromuscular junction. So what this is here is the muscle, okay, and this is the nerve. So we need acetylcholine and acetylcholine receptors to stimulate muscle contraction and muscle function. But here, what is happening is that the autoantibodies have attacked the acetylcholine receptors. So you see here in a normal neuromuscular junction, so you have several acetylcholine receptors here, but in MG, the acetylcholine receptors have been eliminated, or not eliminated, but severely reduced. So there's not necessarily a change in the amount of acetylcholine, but it's a change in the amount of receptors for that acetylcholine to act on. So that's what's being affected here. So therefore, if we can't get the good acetylcholine action at the muscle receptor site, we're not going to have good muscle action. So the person will have fatigue, weakness. There is a theory that the thymus gland, which is generally inactive early in life, still is working and has something to do with the production of autoantigens, which causes autoimmune problem in MG. So often in MG, people still have an active thymus gland. So one way that we diagnose this is with a tensilon test. Tensilon is kind of like the brand name for acetylcholinesterase. But what we do here is that, well, first remember that these words are long, I know, but the acetylcholinesterase breaks down acetylcholine. So we need acetylcholine again to have muscle working at the nerve site. So therefore, acetylcholinesterase, we don't want that around too much during this problem. So what we do is we give acetylcholinesterase or anticholinesterase to a patient to see what happens after we give food to them. So if the patient, we give them tensilon or anticholinesterase, it's a lot of words I know, but if they have improved muscle strength, that is indicative of MG. But if there is no manifestation or no change, then that's a negative test. Does that make sense? Yeah? No? So acetylcholinesterase, which is cholinesterase, if we gave anticholinesterase, it would prevent that, right? So therefore, we would have a decrease in the breakdown of acetylcholine. So if you give it, we should have an improved muscle strength, right, in MG.
How's that measurable?
It's measured with physical exam, and also they can actually do electromyogram to see actual transmission of muscle impulses.
So does the tensilon essentially do what the receptor sites that they no longer have would do?
No, it increases the amount of available acetylcholine, so there's more acetylcholine to work on those few receptor sites that are there. So we get a better response because there's more acetylcholine.
But I thought there was already enough acetylcholine available in MG.
There is, but if you increase it, hopefully you get a better response. Yeah. Or you would get a better response with MG. But yeah, the problem is that right now the receptor site, not the actual acetylcholine. There are these this myelogram that can be done, and it simply detects abnormal transmission of the neurofiber. There's an anti-acetylcholine receptor antibody, and that is a very good test to test for MG. So that tells us if there are antibodies there that is breaking down those acetylcholine receptor sites. The more severe the disease is, the higher this antibody number is going to be. So in MG, the person will have these weakness manifestations, but they improve with rest. As the day goes on, the person's manifestations become worse, and of course, again, these infection and stress increase the manifestation of these autoimmune disorders. There's not a problem with the muscle itself or the nerve itself. So there's no loss in sensation and no loss in muscle tone for this person. It's a problem with making the muscle work. They'll have normal reflexes. So this is a drooping eyelid or ptosis here. Often the person with MG, you would ask them to open their eyes wide, but one eyelid or maybe both with lag. And that's due to the muscle weakness of the face there. So there's problems swallowing and speaking. Of course, there's a risk for aspiration, difficulty eating, things like that. So when the person has a difficulty closing the eyes, they would have a risk for corneal abrasion, dry eye, things like that. Keep that in mind, just like with hyperthyroid with sometimes. Let's see. I think that, why did I do all this? Let's see. I just broke it down, I think, by system here. So, weakness of the peripheral musculoskeletal. So this would give us manifestations of problems with activities of daily living, walking, mobility, things like that. So peripheral, the little arms and legs. So weakness of the diaphragm and the intercostal muscle, so that would impair the person's breathing ability. So impaired gas exchange, decreased ability to take breaths, which person may end up with respiratory failure. What else? Because the person has weak muscles for chewing and things like that, and eating, they would have nutritional deficits also because maybe the fine motor movements of the hands makes it unable for them to cut food or to grasp a utensil. So that increases their risk for malnutrition. So with MG, there's a myasthenic crisis, and this is an exacerbation of myasthenia. So the person at this point, we would most worry about their respiratory system when they're having a myasthenic crisis. But overall, these are manifestations of that high heart rate, difficulty breathing. So most of this is surrounding breathing and the respiratory system, but also speech would be a big thing that we could assess easily when a person has an acute problem speaking. The person's not taking their medication maybe, or maybe there's something that is exacerbating this, like infection. So we'll talk about the anticholinesterase medications. So here the person is having a cholinergic crisis, so there's a myasthenic crisis and a cholinergic crisis. They're very similar, but the problem with cholinergic crisis is that the patient is being over-medicated. So in a myasthenic crisis, the person is under-medicated. In a cholinergic crisis, the patient is being over-medicated. So these anticholinesterase medications are basically anticholinergics. Same word, right? Sometimes to differentiate, if we can't get a good history about medication doses, the tensilon test can help us realize which one is going on. So with the tensilon, with the cholinergic crisis, it's not going to help, but if it's a myasthenic crisis, the tensilon will help. Make sense? Realize that these are medical emergencies because the main issue here that we worry about is respiratory failure. Respiratory and ventilatory failure. This person is unable to breathe because the diaphragm is weak.
So is it going to be really difficult to differentiate without the test?
If they can't get a good history, they have basically the same manifestations. Yeah.
Unless they happen to tell you they have vertigo. Pretty much don't know. So you want to solve it.
Vertigo is a manifestation of MG. Yeah. So it would be myasthenic crisis, right? Go back backwards.
It's a close
Backwards, okay. Okay, so here are the anticholinesterase medications. So it's hard to break it down, but anticholinesterase prevents the breakdown of acetylcholine, right? So we give these medications, and they have those anticholinergic effects. What else? So this simply helps the manifestations. It doesn't affect the autoimmune process. After these medications are given, the patient will have a peak effect in about an hour after giving the medication. So, you would give the medication and then have the patient eat about an hour later to reduce the risk of aspiration during eating. So realize that an hour after giving this medication, the patient's going to have a nice improvement in their manifestations. I might have said this is anticholinergic. It's cholinergic. Cholinergic. I'll say that backwards. Because atropine is the antidote to these medications. So these, I said anticholinergic, but they're cholinergic. Yeah. All right. Can't use these during pregnancy. To help decrease the breakdown of the receptor sites, corticosteroids can be used. Prednisone is the drug of choice for MG. You know all about corticosteroids for endocrine. And again, these cytotoxic or immunosuppressant medications can decrease the autoimmune problem going on here in MG. Pancytopenia, liver affection, and infection. I'll talk about how the person with MG often has an active thymus gland, which is potentiating this problem, or we can take out the thymus gland. It's usually inactive in adults, so it can be taken out. So realize that it probably would be a chest surgery or a lower neck surgery. The anticholinesterase medications are given before to prevent a myasthenic crisis when removing and manipulating the thymus gland. Just like when you're taking out the thyroid gland, you have a risk of a thyroid storm after that because of the manipulation of the gland. So if it's a chest surgery, expect a chest tube. You know all about taking care of chest tubes. Plasmapheresis is a procedure that maybe you're aware of, but I think sometimes it's used in sickle cell. But we can use it in other disorders too. And the use of plasmapheresis in MG is to remove the antibodies to acetylcholine. I think there's a box or something in your text that talks about the nursing responsibilities surrounding plasmapheresis. I think about it as being similar to dialysis. So muscle strength is a major assessment here. We want to make sure that we promote the patient's respiratory status, prevent aspiration, know when to give medication, when they're going to have a good effect of this medication, teach them, to perform activities after having the medication. Remember, they're progressively get weaker as the day goes on. Those things that we do to decrease the risk of aspiration. So ineffective airway clearance would be a priority nursing diagnosis because of the airway or respiratory complications. So we would do all of our nursing things here to improve the clearance of the airway to prevent aspiration, especially of new body heat. Make sure that you know how to do the Heimlich maneuver, the procedure for that. Everybody's BLS though. But make sure that the person is taking care of it. The person with MG may be at home, because this person is going to be in the hospital unless they're on the vent or having severe complications. So make sure that whoever's taking care of them knows how to clear their airway if necessary while they're eating. Rest, again, articulation of speech, slow speech, thinking about articulating deliberate speech there to improve communication. Again, in the morning, after medications is when they're going to have most energy, and that's it.
That was torture to get through this past
Me
couple
too.
weeks. I mean, I meant for you. It was clear.
Yes.
I'll go with the radiation question.
Sure.
PCGB,
Turn cough deep breathing.
I mean, and on the pregnancy one, when the CBY measured.
Childbearing years, use blood control.
Oh my God.
I make up abbreviations sometimes. That's immunology. I think I will. Can you finish it? We're going to revise the nursing curriculum in a couple of years. We're going to Common Core curriculum, basically, across the state. And we're going to have 30 med-surg courses. And my goal is to teach med-surg 30. And I want only acute critical problems. So I gave my recommendations for the things that I felt like fell in med-surg 3. What's it? So that should be in med-surg 2.
You probably don't want to, but several of us have said that you need to be teaching foundation.
No way.
And what?
I would have made, you would have made it so much better that first lesson.
And adult health one.
Want me to
You
do
can
it?
start off. You can start off.
I can teach you, but I can
We have to do this speaker.
Yeah, go ahead.
Did everyone get the email I sent out by chance for nursing convocation? Anyone not get the email?
Okay, again, I am Constance Jones Lester. This is little Constance Lester, but I have both my parents' names. So, I'm 30 years old. I was diagnosed in 2008, October 2008, and I was 25. I started having symptoms in June. I'm sorry, I had to make flashcards, so my memory is horrible. I started having symptoms in June of 2008, and I'm actually having a flare-up right now. That's why I'm not standing. It's the same flare-up I started having. My leg started hurting badly. And I was actually working for the Department of Human Services, and I was on crutches at work. And I ended up going to the doctor I've had so many doctors since then, I can't tell you who it was, but went to the doctor and they recommended that I have an ultrasound done on my leg. So the ultrasound turned up normal, and so they didn't know, what was going on. So kind of dealt with it, and it finally went away probably about 2 months later. And it went away about 2 months later. Then in August of 08, my eye started acting funny. I was like, seriously, this close to the computer screen because I couldn't see. Everything to the left of whatever I was focusing on would disappear. And so I ended up going, once again, I don't know what doctor, I think it was my neurologist at the time. He sent me to Dr. Westbury, which is a doctor at UT. He's a UT. When I went to him, he did all the testing and found out I had dark spots in both of my eyes in the same spot. And he didn't know what it was, so he sent me to have an MRI done. And from the MRI, that's what told that I had, it was white matter, which is what the MS is. Sorry, I'm nervous. Nobody else in my family has. Like, I'm the only person. I've asked on both sides of my family, and I'm the only one with it. So I don't know where it came from. But I have a astigmatism in my eyes. So I have glasses, which I'm supposed to be wearing, but of course I don't. I hate wearing them. Like, I can see, but trying to read stuff, I have to wear them. And looking at stuff far off, I can't see. Like, I couldn't see the sign that said nursing. The nursing theater. I couldn't see that. It took me forever to find this place. Okay. I have relapse and remitting MS. And mine is very aggressive. My ESR levels are high. Something, not even sure what that is. Something with my blood. My levels are high, and we cannot figure out why they're high. So the doctor is still, he wants to do a repeat. And I went to the doctor on Tuesday, and he wants to repeat my MRI. I've seriously had I've had dozens of MRIs done, like every maybe 6 months. So yeah. I was fine until when I found out, before I found out I had MS, I was fine, like nothing going on. So it's like, I seriously had like the worst of everything. So along with my MS came rheumatoid arthritis. So I can't do stuff for a long time, because if I do, my hands look like this after a while. So I have to stop whatever I'm doing. And I became lactose intolerant, so I have lactose pills whenever needed. My blood pressure is high. I'm on triamterene. Have to take this daily. It also has a fluid pill in it, so I have to go to the bathroom all the time. Along with the fluid pill, I'm on furosemide, which is a water pill. So I have to take that daily. With taking this, I have to take, this was a big bottle. I still have a whole other bottle of this. This is potassium. And I am on, no, that's not it. Prednisone. He just put me on prednisone again. I was supposed to be taking it, but I stopped. Because I hate taking them. I do, like, every time I take them, I blow up. I hate taking them. And I have no problem saying this, I was 300 pounds. When I started taking them, I was having to go to the hospital. Now I'll talk about that. I was having to go to the hospital on IV steroids, and I had gotten up to 340 just from taking the pills. I mean, just from taking the IV, and then when I went home, they had me on pills. So yeah, I stopped taking them. But unfortunately, with this relapse, I'm having to take them again. So with that, my blood sugar is always high. So insulin, which he decided he didn't want to put me on. So I seriously have extra at home just in case for this situation. So my blood sugar when I was in the hospital was actually like in the 400s.
Wow.
Yeah. So fun times. With my MS, every time I get a MRI done, I end up with new lesions every time. So I've got them in my brain. I can't even tell you how many I have, but every time I go have a new MRI, I always end up with new lesions. So I don't even know how many I have right now. And I have on my neck also. So even just like turning my head, I can hear my neck cracking. The medications that I started on Rebif, which was 3 times a week. I would have to inject under my skin. That wasn't fun. So the Rebif wasn't helping. When I did the MRI, I ended up with, like I said, new lesions. So I ended up changing to Avonex. Avonex I was taking once a week in a muscle, and every week I would have to change spots. So like my legs, my arms, my back right above my butt, every week it was somewhat different. Then Avonex ended up with new lesions again, so I switched to Jelena, which is the pill. I was happy about the pill because I didn't have to inject again. But that didn't help either. That didn't help. So, like I said, my MS is very aggressive. So, sorry, I talk my hands a lot. Now he wants to put me on Tysabri, which is a infusion. Which I was supposed to start on the 19th, but I had a lot of issues. But I go on the 9th of April, and I'll have to stay for an hour to get infused, and then it's an hour before I can go home. And the Tysabri, I really don't want to take because one of the side effects is paralysis or death, and I'm like, death is not a side effect. I'm dead, I'm gone. But I start on the 9th, so we'll see how that goes. Back in December of 2008, when I first was diagnosed, I was given gabapentin. We were just talking about it. I was given gabapentin to help with my numbness. My hand, my right hand, well, it started with both of them. They were both numb, and this one actually came back in, but this one is still numb. Like, I don't have all the feel in my hand. Like I said, since 2008, and it's still numb 2014. So he gave me gabapentin, my first doctor, and it put me in the hospital. I was paralyzed from the waist down. Like, I could be standing up and could not feel anything. So I was on IV steroids then, and I couldn't feel my feet. And I stayed in the hospital for a week. Yeah. And when I went home, I could not do anything. My boyfriend at the time, my daughter's dad, was having to do everything. Like, I couldn't even wipe my butt. I couldn't eat anything by myself. Write nothing. And so he was having to do everything. And it was one incident. I was in the tub, because I was too scared to stand up. So I got in the tub, tried to get out the tub, could not get up. So he was like, I'm calling the ambulance. I'm like, I'm in here naked, like I'm not It took him seriously about an hour to get me out the tub. And I'm like, now you got me dirty again on the nasty floor. So he had to wipe me all up. So I was like, okay. So, yeah. So, my daughter, we have to kind of watch my daughter. I think most people get it when they're in their 20s. But we're going to have to kind of watch my daughter because she could get it too. And my son, I think he's okay because I didn't get it to 2008 and he was born in 2004. So, yeah, we're going to have to keep a watch on her just in case. I have headaches and migraines daily. I'm on, no, I always say it's wrong, zonisamide. I have zonisamide, which I take twice a day, 2 pills twice a day, 25 milligrams. I have migraines like badly, and when I was first given Topamax, I was given Topamax for dizziness. Found out couldn't take Topamax. The Topamax made me worse. It actually made me more worse, and I stayed in bed for a week. My boyfriend now, he had to take care of my kids for the week. I was lucky because he works at night. He was actually on spring break or whatever. He didn't have to work. He was on spring break. He didn't have to work that week, so he was caring for them. But I was staying in bed the whole week, and so when I finally did try to get up, I'm like, I'm tired of laying here. So when I stood up, I passed out. I passed out and hit the headboard. And so he was like, "Are you okay?" I'm like, "No, I just hit the headboard." Like, come on. So yeah, I'm taking. I'm scared to take new medication. When you see I'm taking all this stuff, I'm scared to take new medications because the incident with the gabapentin and the Topamax. But you know, I'm trying. And then, like I said, the doctor is trying to prescribe gabapentin again. I'm like, "Hello, are you not reading my chart? Like, I'm allergic to this." So, yeah. I started back to school in the summer of, I should have taken that water. I started back to school summer of 2012, and ever since then I've had to go to the hospital for something. I was having double vision in the fall. I was having double vision, and so it's like, seriously, all of you, it was like double the people in this classroom. I was seeing 2 of everybody. So they were, once again, steroids. And so it cleared up. When they gave it to me, it clears up like maybe like the last few days of being in the hospital, because I always have to end up staying a week. And then the spring I couldn't see out of my right eye. Usually it's something with my eye, and it kind of makes me nervous because I'm like, am I going to end up going blind, or, you know, I don't know. So, yeah, I couldn't see on my right eye. So I'm on, like I said, I'm on prednisone, and it always makes my blood sugar go up, and insulin, blah, blah, blah. How can I say that? Okay. Need me to talk about anything else?
No? Questions?
Thanks for sharing all that with us. I know that's very personal, and we do appreciate it. I was going to ask, you said that you had relapsing remitting.
Yes.
Is there generally I really have 2 questions. Is there generally a time frame, like you're gonna have remission for this long, and then you're gonna relapse? I mean, is there like a time frame that you know once you remit, okay, well, I'll probably be good for 2 weeks, or does it just depend? Or
mine usually mine happen, like I said, every semester of school I've had to go to the hospital, so I say every few months I end up having a relapse.
is that because of stress?
And I believe the ass too, yeah, I do. Like, I have this hat on because I cut my hair off. Yeah. I do.
And then I was going to ask something else, but I forgot because I was listening to you. So maybe
I just wanted to know for future reference, if I meet someone who has MS, as far as a patient, when you were diagnosed, and you said you were working at the Department of Human Service, how did that affect your ability to work in your livelihood?
Well, fortunately with this position, I was pretty much sitting down most of the time. But if I did have to get up to do something like filing or something like that, I had to use my crutches. Like I let them know. I did let them know that I had it. You know, I didn't know about the ADA and all the stuff that comes with disabilities back then, but I know now. But mostly I was sitting down for my job.
So how often are you having to go for checkups and follow-ups on your?
I seriously, and not even just for my neurologist, but like I said, with all the stuff that has come on, I seriously go to the doctor, and it may not even be not even just like my primary doctor, or I have I have my neurologist, my primary doctor, then I have a lung doctor, I have a hip doctor. I seriously go to the doctor maybe twice a week. I mean, twice a week. Okay, I'm a little raw right
Is there something that you wish that the healthcare field would like do for you better, or that we would understand your situation more, like people that we would deal with your circumstances?
Well, like I said, most of the people that I've dealt with have been understanding. Like my medical assistants, seriously, I'm not gonna say all. Some are the worst. Like I had one that when I was in the hospital, she would come in the room on her cell phone, and then she would I would ask her something. She'd be like, "Hold on," I'm like, really? I'm the patient. Like you're on your phone. And then I would ask her to do something like give me water or something, and she would not come back. I would have to wait till the next shift to come on and get water. Yeah. But all my nurses have been, they've been good.
And do you have any kind of assistance to help you with meds and hospitalizations or anything? Or how's that work?
Well, pretty much, I pretty much know to take my medication, but it was at a point where I would have to set alarms because I wouldn't remember to take stuff. But it's like I have so much, so I keep everything together now. So I know to take, you need to take this, you need to take that. Like all of this stuff is in a drawer in my house. So I take all these together. And when I take these, then I switch to these, and these are just vitamins. And I try to take these every day. And these are kind of like as needed, like vinegar, because I have allergies really bad now. So I take, taking this as needed. This is allergy again for my nose. And
so what about as far as financially wise though?
Well, I have 10 care, so pretty much all my stuff is paid for. And then if it's something I don't get $5 a month, so my mom's like, how much is your stuff? And I'm like it's too much. I'll wait till next month. But usually I try to keep stuff, keep it to where I have enough to make it to the next month. Like this is a Tylenol 3 acetaminophen codeine, and I just take this as needed. That's why I still have some. I got this back last year, so October last year, and I still have some.
So you basically alternate your medications, like you'll do 5 of them this month, and then 5 of them next month. So they run out kind of every other month. Yeah, like the triamterene, because I'm in school again now. I graduated December, and I'm in school now, so I try to get the little private room. So I know if I take this, I'm probably going to lose my room because I have to go to the bathroom. So I try to take this when I get home in the afternoon because I know I'm going to be up anyway. So I try to take it in the afternoon. So the ones like the furosemide too, because it's the water pill. So I try to take it in the afternoon.
Okay. Will you be able to drive around since you say you have eye vision and stuff?
Yeah, I'm fine now. Like my vision is fine now, but when I start relapsing, then my mom would have to help me do stuff, or my boyfriend would have to help.
Does it have anything that let you know that it's coming, like at the aura? What if you're driving, your leg kind of numb or whatever? Does it happen like you know it is coming?
Well, my leg, I kind of got a feeling because my leg, it was just all of a sudden it started getting hot, and I was like, why is my leg hot? Like I had a heating pad on it, and now it's like I said, I can move it, but it's still numb, and it seriously feels like it's on fire right now. Yeah.
Is that the exhibiting relapse symptom? Is that what happens when you know you're about to relapse or you're going into relapse?
Yeah,
What's the first thing you notice? Is it your leg?
No, well, this, like I said, this was the first symptom I had when I finally, when I first found out I had it. This was my first symptom. But usually it's my eyes. Like, my eyes always end up acting crazy, going out or whatever.
So when you relapse, when you talk about your relapsing, is it normally like for a specific amount of time? Like, does it last for like a couple hours, or like usually when that happens, how long does it normally last?
Well, with my leg situation, they lasted for 2 months. Yeah, and with my eyes, they always end up giving, if I go to the hospital, they'll give me IV steroids, and so it only lasts for like a week. Because, like I said, by the end of the week, I'm okay again.
Do you always have to go to the hospital?
Usually, yes. Like, I probably need to go now, but he gave me the oral steroids, which is probably not going to do anything. Like, I tried to, with me having kids, one of those semesters at school, I was having to do outpatient. So I would just have to go every day for an hour and kind of sit there. They would have me sit for probably about 15 minutes, then I could leave. So I probably will have to do outpatient if I do have to go there. Because that's probably not going to do anything.
How long did you?
Sorry. I noticed that you said that you were not diagnosed. You had your son first before you were diagnosed. Did you have your daughter after you were diagnosed?
Yeah, I was diagnosed 2008, and I had my daughter 2011. And actually, my last 2 months of pregnancy were like the worst. I couldn't even, like, if I would have to lay on pillows, like kind of sit up, sleeping. Because if I laid down, it would take me about 15 to 20 minutes just to get up. And I would be like grunting and stuff because it would hurt badly to get up.
Are you able to take the medications you were prescribed while you were pregnant?
No, I think the steroids and my, I think I was on Avonex then. I couldn't take Avonex because you could miscarry, so I couldn't take those.
Did any of the symptoms improve while you were pregnant?
No, no. No, I think I was able to take this acetaminophen. Yeah, acetaminophen with codeine. I was able to take that because they said it wouldn't be harmful to her, so I was able to take that. Like, I'm on lower the hydrocodone, I couldn't take that.
Is there anything other than medications that you found that helps with the pain? Like, I mean, hot or cold, like activity or rest, or is anything, like I said, other than the medications that's helped with any of your symptoms?
Well, I had started working out at school, but considering the prednisone and with the relapse, I haven't been able to go. But I started working out every day. Just like I would walk 2 miles. I would get on the treadmill at school, and I would walk for 2 miles every day. And I don't eat meat anymore. I stopped eating meat. Like, it's seriously, I would eat it, and it would make me want to throw up. So I quit eating it.
Has it made a difference, or did that exercise help with, like I said, any of the pain or the actual symptoms though? Or did you notice a difference or any relief in it?
Yeah, it was helping, and I actually felt, I felt better, and I had a little more energy because I never had any energy before I working out. So I had a lot more energy. So yeah, I don't, like I said, I don't eat meat anymore. And some of that meat that I was eating, it was like, when I would eat it, it would feel like it was kind of clogged in my chest. And I would have a lot of acid problems, so I had my acid pills. Like, I haven't had to take these in a long time now. And I don't know if it's because I, changed up how I eat, because I don't drink drinks anymore. I pretty much drink water now, all water. And not eating meat and, a lot of stuff with acid in it.
How'd you feel when they first diagnosed you with that, when they first were like, this is what you got?
No, it's funny, and I didn't write it down. I was actually at work when he told me, and I was like, oh, okay. And then I was like, what? So I said, went to the restroom, and I was like, what, repeat all that again?
He told you over the phone?
Yeah, he called me when I was there, and I told him I was at work, because I was like whispering, because I wasn't supposed to be on the phone. And I was like whispering. I was like, oh, okay. And then I hung up and I went to the restroom, and I was like, okay, now what? Repeat that? And I was like, oh, okay. Like, I was kind of shocked. Like, really? Like, I didn't even really know what it was then. Like, I've heard of MS, but I didn't know what it was. I was like, oh, okay. Like, all right. Then I like went home and researched everything. That's how I am. I was like, okay, then. Good to know.
Are there any MS support groups in Memphis that you know of? Are you part of any MS support groups?
They do them. They don't do them all the time. They do have them. I haven't joined any, like I said, because I have kids and my kids are like bouncing off the walls all the time. So I haven't gone to any. But if I do have questions, I have the MS Active Source, which is a 1-800 number. So I will call them, and they usually are really good about calling me. Like, I usually don't have to call them at all.
What kind of vitamins are you taking in? Is it something that you felt you needed?
Yeah, I was trying to do the holistic thing, and I was like, I hate taking pills, but like I have to take them. So this is a 1 a day. This is a calcium, magnesium, zinc, which is actually help my hair grow. And I took it off. Like, I have a fro right now. Like, I was so stressed I cut my hair off. This is B12. This is fiber. The fiber is actually, I was actually just taking this at first, and it kind of helped with the energy. Vitamin D. I can never pronounce this right. Is it Cassia? Yeah. I take these every once in a while, but I usually don't really take these. And kind of to help me sleep, I take because like I said, I do have allergies really badly. Like, every time I go to the doctor, they end up having to give me a shot in my arm because I always end up having sinus infections. So I usually, if I can't sleep or something, I will go ahead and just take 2 of these at night. Like I said, I have issues. Right now, it's psychology.
So are you able to work with them?
I can work as long as I sit down. Yeah, as long as I'm sitting, I'm good, but trying to walk around and do stuff is not going to happen. I've actually, and that's what I meant to say too, I've actually been fired from 2 jobs because one job was on a point system, and you can only have like 3 points, and I was at 3, and they like let me work the whole day, and then they were like, oh, you're fired. I was like, oh, okay. Like, I wasn't even mad about it because the job was crazy. It was very stressful, so I wasn't mad.
You be able to on disability?
I applied for disability, and I finally got a court date like after 2 years. After 2 years, I got the court date. Got in the courtroom, and the lady was like, she didn't even like hear the case first, and she had already told me, she was like, you're young, you can still work, so you're probably not gonna get it. I'm like, you're the judge, of course I'm not gonna give your signal. You're the one that has to decide. It's not gonna happen anyway. So end up not getting it, but I was trying to tell her everything that I had, and she was not hearing it. And then I had to appeal, and they lost my paperwork. The judge I had lost my paperwork. So they're like, you have to reapply again. I was like, oh, okay.
Of course.
Yeah.
Do you get that a lot from just general people? They don't think anything's wrong with you? Because they see you doing other things. They don't know what happens at home and how many times you go to the doctor. You say, oh, I've got MS, or they don't know that anything's wrong with you?
Like my boyfriend situation. I guess he doesn't believe that it's as bad as it is. Like, he's like, oh, you can do this, you can do that. Like, you don't need me to help you. Like, trying to clean and stuff. That's the worst. Like, I seriously have to sit down to wash my dishes. And he's like, you can do that, because I asked him to watch it. He's like, you can do that, and I'm like, come on.
That's just any man that you try to get.
But for the most part, like even my son understands. After years of having it now, he understands now. But yeah, I try to take my cane around because half the time it's like I'm drunk trying to walk without it. Even if I don't, I try to walk without it, but at least I still try to have it on me. And there was one point. This was the reason for the cane. At one point, within a month's time, I had fallen over 10 times. Yeah, me and stairs aren't friends. Stairs are not my friends.
You better use that cane.
Yeah, and that's what my nurse told me the other day. She's like, you need to use your cane. I'm like, I'm carrying it.
Okay, this might be like a tad personal, but with your condition and then how long you've been diagnosed with it, like what is your outlook on your disease? Like are you dealing, are you coping well, or do you still have a lot of like depression or anything?
I think we all need to.
Yeah, I do. It's like I'm alive, so hey, I'm alive, so it's like, I'm hurting, but I'm hurting, but it's like I'm alive, so I deal with it. Everybody asking, how are you doing? I'm like, I'm making it. I'm alive, I'm making it. Like I'm not mad about having MS, like being able to come in here and talk to you all, even though I'm nervous.
You did a great job.
Yeah, you did.